Good afternoon and warm welcome to the Waterfalls Initiative for Continuous Education from UAE to the World. I'm Dr. Spatika and will be the moderator for today's session. Today we have Dr. Prem James Charles, who is with us and who will be talking to us about the current concepts of arthroscopic labral repair of the shoulder. Dr. Prem James Charles is an MBBS and MS Orthopedics, a specialist orthopedic surgeon, and medical director at Asta Specialist Clinic for Orthopedics and Physiotherapy in Dubai, UAE. He has over 9 years of experience in the surgical and medical line of orthopedics, a very active surgeon trained in advanced trauma, arthroscopy, and arthroplasty. He has been doing many knee and shoulder arthroscopy procedures in Dubai, along with hip and knee replacement surgeries. And these surgeries he does in hospitals of our Asta Hospital Mankhoon, Asta Hospital Kusais, and Medcare Hospital in Dubai. Dr. Charles completed his MBBS in VMMC Karaikal in 2004, following which he underwent training in accident and emergency medicine in CMC Vellore for 2 years, post which he attained his MS Orthopedics in VMMC Karaikal in 2010 with a gold medal and university first rank holder. He has fellowships in accident and emergency medicine from the CMC Vellore, arthroscopic surgery from World Laparoscopic Hospital, New Delhi, arthroplasty fellowship from Switzerland, and arthroscopy and sports medicine from CHUV Hospital in Switzerland. For those of you who'd like to ask us question and answers, request you to please put in your questions into the Q&A window in the right side, and we will take this up at the end of the presentation and request Dr. Prem to enlighten us. We also request you to click the download certificate button at the right when you are done with the session for getting your attendance certificate. With that, I will open the floor and request Dr. Prem to please take on the session. Dr. Prem, over.
Yeah, I'm just sharing my slide. Thank you, Dr. Spatika, for giving a brief and wonderful introduction. I'm just about to share the slide. I hope you could see the slide. Is it visible?
Yes, Doctor.
Yes.
It is.
Anyway, thank you, Dr. Spatika, again. It was a wonderful and a brief introduction. And I'd really like to thank the organizers for giving this wonderful opportunity to talk on this platform. It's been very successful. I see it. I see a lot of their sessions going on, and it's been a huge learning platform for many of the doctors and physicians around the world. Anyway, today, going to the topic, today I'm planning to talk on the labral, basically on the labral tears, and then we'll be talking a little bit on the arthroscopic labral repairs, which I usually do in the hospital. I work, as Dr. Spatika said, I work in the Asta Special Center for Orthopedics and Physiotherapy, and I operate in the Asta Hospital, which is just nearby. The shoulder, this is one of the most common injuries which I usually see in my day-to-day practice, and we need to know when to identify them. Now, the overview of my presentation is going to contain the goals, the history, the epidemiology, the etiology, the anatomy, which we need to know in basic, at least to understand what we are looking at and how to understand the basic of the care as well. And the classification is very important to plan the treatment as well. Signs and symptoms, I'll be looking into it, and as well as the diagnostics tool, how to identify and what kind of tools we can use to identify the tears. And the treatment plan, which I usually do on my routine basis, which I'm going to talk to you in brief, and with the rehabilitation guidelines, which I generally follow in my center. The goal is obviously for any doctors to have a proper history, and we have to evaluate the painful shoulder, and always we have to make sure we do a careful examination of the shoulder and do the special testing of the shoulder to identify these tears. And at the end, it zeroes down to management of the shoulder, which causes pain, and we have to identify the tear or the tenderness according to our physical examination. as per the history is concerned, although we know that Bankarts described the recurrent dislocation of shoulder in 1983, Andrew was the first to describe the labral tear in 1985. And Snyder coined the term SLAP in 1990, and he classified it into 4 types, which I'll be describing all the classification later on in the later slides. Pretty interesting. Andrew in 1983 did a study on 73 baseball pitchers, and he found the lesion in most of the labrums in 1983. Now, obviously, when we look into any anatomy, I mean, we have to understand the basic anatomy of the shoulder, so the pathology will understand better. Now, when we look at the anatomy for this labrum, basically the shoulder is a ball and socket joint. The glenoid fossa of the scapula is quite shallow, as we all know it. And it's quite small. The labrum is made of actually a fibrous scapulous tissue all around. It's just like a gasket. And we can even say it's like a meniscus in the knee joint. It prevents the shoulder ball from sitting out. It has 2 main functions. It deepens the socket and creates a suction cup effect for the joint. And we do have other stabilizers, which I'm not going to talk to you. As you know, the rotator cuff, supraspinatus, infraspinatus, all the other muscles are all around. And we have the other ligaments like the middle glenohumeral ligament, the inferior glenohumeral ligament, and all the other structures to stabilize the shoulder as well. But labrum is one of the most important as well. So we do have anatomical variants which we should be aware of so that we understand it. One is the superior labral recess, which is also seen sometimes in the arthroscopy. It's basically a sulcus located under the biceps labral junction, or it can be a sublateral foramen where the orifice is between the anterior superior labrum and the anterior glenoid as well. And the Buford's complex, where there's an absent labrum with a thick cord like medial glenohumeral ligament. Now, this sometimes surgeons tend to repair thinking it's a tear. So we have to know the variance time to identify these things so that we don't do unwanted repairs on these. Now, when you talk about labra on the whole, we know that there's a 360-degree all around the shoulder, but so we have to understand where and what we are going to talk about today. Slap tears are something which is in the anterior superior part. As a labral, this is attached to the biceps, and it's very, very commonly torn among the baseball pitchers, the cricket bowlers, even the badminton players who smash, get hard smash. So, and the anterior labral tear is something where it's seen in dislocators, the patients who dislocate, who have traumatic dislocations. The posterior labral tear is otherwise known as reverse Bankart's tear. Again, there's another form of dislocation. And we do have degenerate tears where we don't do much about it because it's seen mostly in elderly people. But if it's painful, then we have to think about something. Now, when we look into the epidemiology in our clinic setup, among the shoulder injuries, it's like the shoulder pain is one of the most common joint pains which we see in the clinics. It accounts for less than 5% of all the shoulder injuries, and it's most commonly seen in the dominant shoulder and overhead and throwing athletes. So as far as the etiology is concerned, when you look at the mechanism of injury, it's a repeated overhead activities that is throwing over the head with or a fall on the outstretched arm with a tensed biceps. Even a traction on the arm can cause a rupture to the slap or the superior labrum. Pathoanatomy can be because of the tightness of the posterior ilioglenohumeral, which causes a shear pressure on the superior labrum. We have to look at other associated conditions like internal impingement, GERD, and rotator cuff tears and instability as well. So the GERD is basically a glenoid internal rotation deficit seen in some players where they feel that they're going to lose, they're losing their power, and they just start throwing underarm, and we might mistake it as a slap lesion as well. And we should be aware of this condition. We might be treating it as a slap, and it's more, sometimes there's 25% of the slaps associated with this condition. And as I said, classification is something which is very important for us because based on the classification only we can decide on the treatment plan of any patient. And yes, there is always an inter and intra observer variability for any lesions or classification. Snyder, as I said, had the original classification, which included from 1 to 4. And later on, Mafford extended the classification to 5 to 7. So as far as the classification of the SLAP is concerned, type 1 is actually a degenerative fraying of the superior labrum, but the biceps anchor is still intact. And the other type 2 is something which is very commonly, as I said, over the baseball pitchers, the cricket ball players, where the detachment of the biceps organ is seen, which I'll be showing in my later videos, and we'll be talking on that, how we repair it as well. Then we have the bucket handle tear, where we just do, it's just like the bucket handle tear of the knee, where it's like it's attached at each end, but the biceps is intact. And we can do a debridement of this. And same thing, intersubsist tear for with the bucket handle tear in type 4. Now, when we look at the signs and symptoms, so we have to focus on the history. They'll say they sometimes feel a pop sensation on the shoulder during an overhead activity or a traumatic event. There'll be usually a vague pain in the shoulder, very, very commonly described. And sometimes some patients say that they have, the time of injury they would describe, and the pain of onset was a little later. So we have to just watch out, because it can be like little contracting a little bit, but you have to watch out and examine accordingly. Mechanical symptoms of popping and clicking is something which is very common the patient might describe, and in fact, some of the patients will tell us that they don't have the power as before to do a badminton smash or throw the ball in a cricket ball. The bowlers, they don't have enough power, and they start throwing underarm instead of overarm. And then sometimes the sense of instability would also be there. So based on these symptoms, we have to do some clinical provocative tests, special tests in the clinic. There are many and plenty described. And as I mentioned in my these are some of the tests. But then the O'Brien's, the Speeds, the dynamic lab shear test, the Kim biceps load test, the resisted supination external rotation test, the upper cap test, the Kibler anterior slide test, compression rotation test, Eggerson's test, apprehension test, and we have many more like the relocation test and the sulcus test. But we wouldn't have to do all of these. But in my practice, I'm more focused on these. These are the tests which I look into. One is the biceps provocative test, that is the speed test, Eggerson's test, and Kibb's load test, which I'll be describing how to do these. And for the strap lesions, I might look at, if I do suspect that, then I do the O'Brien's active compression test, the Crank's test, the dynamic labral shear Myers test, or the Kilber's anterior slide test. Now, in the O'Brien's test, it's pretty easy, where what you do is you take the arm forward to 90 degrees, the elbow fully extended, and the arm is adducted at 0 to 15 degrees. And then you pronate the arm with the thumb down. And if it creates a pain, then we know. And we push the thumb forward down, and we know that there's a labral tear. The Karan's test is almost a little similar, but the patient is in supine position. The arm is elevated at 160 degree in the scapular plane, and the body is pushing in, and axial internal rotation and external rotation is done. If they hear a clicking or pain, again, the test is positive for the tear. And then we have the labral, dynamic labral shear test, where the patient is supine and the arm at the side of and the elbows flexed at 90 degree. And the external rotation and abduction at 90 degree. And if there's if there's pain deep or posterior, and at 90 to 120 degrees of abduction, then it's positive. The speed test is basically another very simple test which can be done in our clinics. It's extremely done, which I usually start off with these tests. The patient is either sitting or standing. I tell the patient to extend the elbow and keep it fully supinated, and I tell them to move it forward with resistive action. And if there's pain in the shoulder, we know it is there's a biceps pathology. It can be even, but the speed test is not specific. It can be even a tenodosis, tendonitis. So we have to watch out, but it does tell us that the location of pain is the same. Then we have the Kim's biceps load test 1 and 2, which is actually a little more specific and sensitive test. The shoulder is at 120 degrees of abduction. The elbow is at 90 degrees of flexion, as you can see in this picture. And it's actually an operation position where we do for shoulder dislocations, where we try to see if the patient is having an anterior labral tear. And the examiner keeps the forearm resisted, and we tell the patient to move it against resistance. Flex it is the elbow against resistance. And if there's pain, yes, the test is positive for a labral tear. Now, this is from an article on 2014 from Shoulder and Elbow journal, where described by Magnus. According to them, as I already described, there's so many tests involved in the examination of the shoulder, and there are a lot of pathologies involved in the shoulders as well. And when we talk about SLAP and labrum, there's no single test which accurately diagnose the labral pathology. The clinician must use evidence from the clinical history combined with selective use of interpretation of tests which they are familiar with. And as I said, sometimes some tests are a little more specific. Like, for example, Jones, in one of his journals, has published that biceps load test is most specific and sensitive test. And it depends from surgeon to surgeon, which they like to do more in their practice to identify the tear. And they zero down to the diagnosis. Now, coming to the diagnostic tools, as we all orthopedicians will be doing a normal X-ray for any patient with pain in the shoulder. And most of the shoulder labral pathologies will be normal. The X-rays will be normal. But in case if it's a recurrent dislocation shoulder, we have to watch. We should look at for a hill sac lesion or a bony Bankart lesion, which might be picked up in the X-ray as well. The MRI is a more sensitive tool, and the sensitivity increases with arthrogram when suspicion of significant labral tear. As I said earlier on, the sensitivity is 50%, and if with 90% is increased with arthrogram. There are many other lesions like paralabral cysts which can be identified in the MRI, and there are plenty more pathologies. The MRI, when we are talking about labral lesions, we have plenty of more to talk about. Which I'm not going to go into complete, I'm not going to elaborate all of them. There are too many labral lesions, but we're going to look at the basic ones, which we do see in our day-to-day practice. So coming to the treatment, does a labral tear require surgery? No, it does not. When determining the best treatment plan for a labral tear, there is always multiple factors to consider. When it depends on the size of the tear, which is very important. Now, the tear is very extensive from top to bottom, from 2 o'clock to 8 o'clock, and we have to judge if there's instability as well and pain. Then we can consider to do something. Now, if it's a SLAP lesion, yes, then we have to think about, and the patient is using a dominant hand, and it depends on his activity level and the age of the patient. Then we have to think about either treating it conservatively or doing a surgical intervention. Now, the bone loss is also another factor, which when we look at the exercise, as I said, we have to think about and probably plan CT cuts for some patients when we do an MRI to assess the hill sac lesion, to know if the off-track or on-track lesion in terms of when we look at recurrent dislocation of shoulders. So there are a lot of non-operative. We generally start off with many non-operative procedures, like we give them rest, we do physical therapy, and we start with the NSAIDs, basic NSAIDs. And the first line for any treatment is to address, as I said, glenoid internal rotation deficit if present. That again, we do physiotherapy again, and rehab for the scapular dyskinesis and rotator cuff strengthening for all patients. Injection cortisone, I don't do it much in my clinic unless I suspect biseminal tendonitis. And I generally make sure that if I see it, do an MRI and just see if it is definitely tendonitis, then I think about cortisone injections. Now, so when we come into the operative part and we end up going to the operating room, one of the most common positions which we can keep the patient is either the B chair or the lateral decubitus, but I'm more comfortable with lateral. The B chair, because of the risk factors, cardiac risk factors, I am more comfortable with lateral, and I keep doing my patients with lateral position. Now, we are just going to look at a video of a slap tear, a basic slap tear. It's a patient who's a frequent badminton player and who came into my clinic who suddenly said that he didn't have the power after a snap in his shoulder. And he said that he couldn't give the power shots like he used to. He was probably just 31 years old, and he was very much worried about it, and he couldn't play for almost 6 months. And the MRI, we did diagnosis. Now I just started with the diagnosis scope. We had a look, and I'm creating the anterior portal. As you can see, this is the switch stick which we use to in between the biceps and the subscap. I'm trying to insert my the cannula inside. My standard cannula, I usually insert is either 7.5 or 8.5. So after the cannula insertion, I make sure all the degenerated tissues there, which you can see in the lesion superiorly, is shaved off. Not completely, at least at the edges. The frayed tissues have to be removed. You can see the joint is looking really good otherwise, since being young. I don't take too much of the tissue, just take the edges off of the degenerated tissues. And you can see that's the biceps tendon over there. I just do with RF ablator, I do just smoothen out the tissues. Oops, I think the slide moved forward. Oh. So with the probe, I make sure the labrum is intact anteriorly below 1 o'clock position. But as you can see, the labrum is definitely, the slab is definitely toned. There was a little bit of extension to up to 1 o'clock position. You can see that. You can see the tear over there. So I use a suture, a laser device at 90 degrees. My preference is the 90 degrees, but there are, 70 degrees, but there are surgeons who use a spiral one. I'm more comfortable with this. And make sure we take it at the edge with enough tissue in place with the labrum. This pass metal thread and retrieve that off. So we can shuttle the sutures. Now the suture can be either put as single or a double. I usually put a double and loop it. In this case, I put a single because it's just on the anterior side, on the superior side. And then I use a cannula just to guide me and just drill a pilot hole. It's very important to make sure that it's on the face of the glenoid a little bit. We should not go too posterior as well, anterior as well. When we come a little inferior, we have to make sure there's a bumper effect on the labrum. So I generally use a peak anchor. This is a standard peak anchor, which we use. This is basically a knotless anchor, so it makes life easier for us. Tap it in. And we have reached up to the laser mark. And after we reach the laser mark, we tighten the threads again. So the labrum comes on to the glenoid. and reach the next laser mark so that the anchor is fully intact and in. There's just one part of the thing, then I just make sure that the other tissues which are little synovial, that we could see it's a little bit of synovitis, so I just make sure that I burn those up. And I pass the lasso. This is one thing which I do. I pass the lasso behind the biceps tendon, and I treat it from above the superior side, which I find it more comfortable to take. You can see it's actually torn. You can see it from this part of the video. It's actually torn very badly. The same technique, I shuttle the thread around the biceps. Again, I use the trocar, create a pilot hole with the drill. And pass the next anchor. This is a simple slab repair which is being done. Sometimes we do see this kind of bone getting elevated. You don't have to worry about that. First, go to the laser mark, as I said earlier on, tighten it, good enough. We have to make sure we don't strangulate the biceps tendon too much as well. So the two secured sutures are in place. And then what I generally do, I do subacromial acromioplasty as well to create a free space. And this is what I'm doing in the same patient. In fact, the patient is back into his badminton game. It's almost 1 year back I've done this surgery for this patient. And he is back in game. He's back into his badminton. I have his rehab video at the end of this slide. So this is one. And then sometimes we have we have a combination of a bank cuts. Now, when we talk about bank cuts repair, and it can be in combination with slab lesions as well. This is a little shorter video I edited so that we can rush it through. Now, this is a patient who had around 10 dislocations, and he's pretty young as well. The good thing about him, he didn't have a big heel sac. So there was not much of an off-track lesion. So I just thought, let me plan a simple Bankat's repair. You can see the labrum is badly torn and it's retracted behind. So but a lot of degenerative tissues because of several years, and he's pretty scared of surgery. This is a very important part of the procedure where you rasp the edge of the glenoid, making sure we have a bleeding surface. And you have to make sure this technique is almost the same where we pass a lasso again. And make sure that it's on the face of the glenoid. So the sutures, keep the trocar in, and again, create a pilot hole and pass the anchors. Always check it with a probe, how good it is. You have to make sure when you suture these anchors, you have to make sure we have bleeding edges in the glenoid as well. That's why we need to rasp it, which is very important. Now, this is the slab part of the same patient. He had a lot of, I thought, in fact, if he was above 40 or 50, I might have done a tenotomy, but he had a very good, there was no tenodesis in that tendonitis in the biceps. So I just planned. Sometimes when there's a combination, when there's an off-track lesion, what I generally do as an arthroscopic, I add a ramplassage to it, where we go posterior and we fix an anchor with a capsule to the heel sac area. And that makes it stable. I'm sorry, I don't have a video on that, because, which I keep doing it quite often. So, but that is something which we have to decide before planning the surgery. And sometimes when we are keeping the patient on table, we'll see the dislocation occurring even after the anterior repair. If you do have a doubt, then you can add ramplassage to it. The only problem with this is the stiffness of the shoulder, and you have to give enough rehabilitation for these patients. Generally, we don't operate on degenerative tears, but very rarely when there's no trauma associated. Now, this is one video where you can see a degenerative tear, but this patient, why I decided to operate was he was in intense pain, and he was only 34 years old. And you see the amount of degeneration you can see in his shoulder joint, which is not normal for this age group. The first video, you might have seen a very good shoulder, which is a simple slap. But this patient, when I went in and I started seeing it, I was really surprised to see so much of degenerative changes happening in. He's a daily wage laborer, but unfortunately he couldn't do his job because of which, and he came to me for help. He had undergone all forms of conservative management, starting from physiotherapy, a lot of physiotherapy sessions done. And now what I'm doing right now is I'm actually clearing up the frayed tissues which are there. A lot of synovitis, as you can see. I saw a lot of, in this later part of the video, you'll even see loose bodies inside the joint as well. This looked really bad. And smooth around the tissues with the RF ablators, which is very, very, very important. This wand is very important for any orthopedic or arthroscopic surgeon. I tighten up the tissues as well. Then I check it with a probe. Although the patient didn't complain much of instability, but I know the cause of this degeneration is because of the little bit of instability which is having. See the hairy part of it, it's really bad. So again, you have to use the RF ablator to smoothen that out as well. As I said, loose bodies were seen and taken off for this patient. A lot of loose bodies were there. In fact, even as this previous procedure I said, the rasping is very important. Make sure you have bleeding edges. You have to give enough time, elevate the labrum. You can, in fact, sometimes pass the scope and through the anterior portal to see how deep this tear is as well. That helps us and guides us to lift up the labrum. I'm doing the similar procedure again, passing the lasso in, shuttling the threads. I generally loop my threads so that it has a good hold. You don't have to do that, but then I use the strucker again, the similar, to create the pilot hole. This is another anchor with the eyelet, which really helps us to guide through the hole. It's very important to create this bumper effect, and it's very important in Bankhart's repair. In fact, tighten the threads. Pass it up to the laser marking like any suture anchors. Always check it with a probe if you've achieved good enough stability. I think enough anchors would help actually. You can see as the bleeding is taking place, which is very important. Most of the patients, the anesthesia is in hypotension, so we don't see much bleeding, which is good for us also in the field. Let's see the bumper effect on the labrum, which is very important. Passing it. Something which you have to achieve at the end, I mean, the proper stabilization of the shoulder. So this is very important. So we need to keep, and I sutured it up to the 1 o'clock position for this position as well. We have a significant tear. Now, the post-op rehabilitation is something which is extremely important for after any surgery, especially arthroscopic surgery. But yes, it's very important to plan it out. In Labram, and we plan it as phase 1, phase 2, and phase 3. And phase 1 general protocol is in the immediate post-op surgical phase, which is protected motion from day 1 to week 6. In phase 2, it's an intermediate phase where there's moderate protection from week 7 to week 14. And phase 3, which is a minimal protection, which is a phase where it's week 14 to 20, which I'll tell in detail, which is in the next slide. So in the phase 1, generally what we do is very simple. From for 0 to 4 weeks, there's no much of, we keep them on a sling, but then we encourage pendulum exercise only. No active elbow flexion or shoulder elevation. 4 to 6 weeks, 4 to 5 weeks, we'll remove sling off, and then gentle isometric exercise and the elbow by the side. Scapular mobilization should be done, and the range of movement to be achieved is 85 degrees and external rotation at 30 degrees and internal rotation at 60 degrees. 5 to 6 weeks, we increase all this range of movement, like the range, as I said, abduction to 145, from 85 to 145. Flexion, again, we increase it to 145. External rotation again is increased, the internal rotation increase to 45 degrees. And we eventually start increasing every phase at a time. In phase 2, whereas weeks 7 to 9, again, progress increase in the range of movement. And then we begin isotonic rotator cuff and shoulder strengthening program. And week 10 to 12, again, we progress to more range of movement extension. Phase 3, again, is a phase where they are, as I said, where there's almost 3 months down the line. We have to resume to the activity and restrict the sport activity, and they can slowly go on to the sports, but start at a very minimal level later on. So we have to make sure that the idea of doing any surgery is to make sure that they are able to achieve or go up to the pre-injury level. Now, these are some of the patients who have done the surgery, and this is the first patient is a recurrent dislocation of shoulder who had around 4 or 5, in fact, one of my staff. And he's already hit the gym and he's pretty happy with it. And he's in the gym doing all the exercises right now. This is the next patient is the one I showed as a slap lesion, who's a badminton player, and who now has gone to his pre-injury level of sports after that simple repair. And this is that huge Bankhart's lesion, which I showed you in the second video. And he had that 10 dislocations in his lifetime, and he was in pain. And he is one of the daily wage labor who had the pain in the shoulder. And you can see his rotating, keeping the back as well. Most of these videos are after 3 months. Now, when we come to any study, we have to go through the scientific publications as well. There's one from the American Journal of Sports Medicine published in 2010, where the outcome of arthroscopic and type 2 labral tear, where they found that they had excellent results for patients older and younger than for 40 years of age when a proper suture anchor has been used. And always we did have significant good results with the type 2 labral repair. Now, another publication in 2012, where does age or gender of the patient influence the outcome of type 2, where in this study, they studied 38 male and 34 female patients, and they found that the Oxford shoulder score, the reported 94% good results. And so according to them, the conclusion was neither the patient nor the age above 50 affected the outcome after the surgery. These are basically for slab repairs. Now, when we talk about one of the retrospective studies published in 2020, where for anterior dislocation, traumatic anterior dislocation, where a total of 100 patients were studied, which showed they did a mean follow-up. It was a retrospective study where a follow-up of 8.3 years was done. The overall recurrence rate was 22. So, and most of them were of the age of 30 years. Now, one of the journals where the orthopedic journals of sports medicine, where 39, this is for the adolescent patients where, for Bankat's tear, repair has been done, where the age range was, the study was between 15 to 19 years, where the mean age was 16.9, and the follow-up was 6.3 years, where they did see a significantly good results for these patients, the younger patients, where they restored the stability to 90% of the cases, and almost 80% of them returned to their pre-injury level of sports. Of course, with time, we need to know, before any surgery, we need to know the complications of any shoulder repair or any surgery. In fact, this is a publication done by the current review of musculoskeletal medicine in 2014, where describing all the complications that can happen, and we should be aware of it too, and we should know the anatomy and every aspect of it to how to deal with it. Nerve injuries are sometimes there. We have to be very careful when we go to the inferior part of the labrum, not to catch an accident nerve. Even when we go, as you know, when we go to the subchondral space, suprascapular space, we should not look at we should not injure the suprascapular nerve. In fact, infection is something which is common, seen all around the world, but we don't see it in a day-to-day practice in arthroscopic surgeries. Problems associated with suture anchoring. These were seen mainly in the earlier days where biopsical sutures were used, and there was a 30% failure rate. Now with the latest PEEK anchors, we don't see much of that, and it's reduced significantly. The failure rates are very less with suture anchors. Osteoarthritis is something we should be aware of. Post-operative stiffness is another complication which we should be focusing on, because after any of these labral repairs, we should make sure the rehabilitation program is good enough. Most of the patients we have to do a significant amount of counseling for these patients to make sure they are aware that they have to come to our clinic to get the rehabilitation done. Otherwise, they would miss out on this and they end up coming with severe stiffness. Recurrence instability is another complication which I mentioned earlier on. So all this we should be aware of, and we should understand it really well. The take-home message is should all labral, as I mentioned, not all labral tears require surgery. We have to treat some of them in a conservative, not some of them, most of them, but it depends on the age of the patient. If the patient is young enough and it is happening the dominant hand, then we have to decide on how to go about it, and is it disturbing his day-to-day life. And in case if there's a significant instability, like for recurrent shoulder dislocation, we have to plan CT cuts for bony lesions, for off-track and on-track lesions, and then we have to plan open or arthroscopic procedures. Not always we can go arthroscopically. We have procedures where we can go open. Like for example, in the recurrent dislocation shoulder, if it's off-track lesion, we have to think about open latarjet. Yes, there is arthroscopic latarjet, but open latarjet is the most common bony procedures. And we do have other open procedures as well, capsular atrophy. But so we had to decide it according to, sometimes we might have to take CT scan for that as well, not only MRI. Thank you.
Thank you so much, Dr. Prem. That was so thoughtful to put in those videos, and we could actually see those wonderful surgeries that you do. As they say, when you see it, it makes so much more sense. So we have a few questions from the audience. if you don't mind me asking them.
Yeah, sure.
So you were talking about, talking about the SLAP um, mode
Yeah.
of surgery and the two different types of modes of surgery that you prefer, and you preferred the SLAP over the other. So have you done any of the surgeries which are not SLAP, and were they very specific to the way your patient presented? Or was it because of some other reasons that you chose not to do the SLAP?
See, honestly tell you, the slap lesions are the most symptomatic ones, Dr. Spatika, because what actually happens in slap lesions, see, we are in a more of an orthopedic center, which is more sports medicine based, where patients come after a sports injury. And yeah, you see, most of the patients, they come that they lost their power to the arm after one single throw, hearing a popping sound. And the most of the time it will be a slap lesion, which is, a query that comes on our heads, based on the clinical findings, as I mentioned earlier on. We do all the clinical tests, provocative tests, and then we identify that it comes in our mind, yes, it could be the tear. And then we zero down by doing the MRI. And once it comes to that, yes, then we decide, counsel the patient accordingly. If he wants to leave it off, he can leave it off, but put him through a physiotherapy program. But if he wants to go back to his physical sports activity, and most of them do, especially the ones below the age of 40, then yes, then I go in for the repair. In terms of the other tears which we talk about, as I said, the anterior labral tear is sometimes more dislocation oriented. I mean, it's most of the patients with instability. Now, if we look at the degenerate tears, we generally don't touch, especially beyond the age of 40 to 50 years of age. Some of the patients, the MRI does pick up the degenerate tear, and only if they're symptomatic again, then we think about doing a diagnosticoscopy. And one of those videos was a diagnosticoscopy, and I ended up seeing a huge tear, which I did see it in the MRI, but it was significantly big, so I didn't feel like leaving it. And the patient was 35 years old, which we don't see is very common. So slap lesions are some of the most common ones which we deal with. Yeah.
What would normally be the causes of such kind of a degenerative tear? I mean, in younger people, is that
See, it depends on
trauma?
yes. So it depends on the work nature as well. Now, this one particular patient, the patient is a daily wage labor, is used to carrying heavy weights. He might have had a pre-injury a long time ago, which he was not aware of. And over the period of time, he developed all this degeneration and arthritic changes in the shoulder. And the pain because of this loose bodies in, as I showed you in the video, really created trouble for him. And he couldn't do any of his work. He couldn't do any of his job. And he came to me. He had done a lot of physical therapy, and he didn't have any results. So then we ended up doing the surgery on him.
And how long did it take for him to get back to normal, Dr. Prem?
4 to 5 months. In fact, I did give him an extended time because he is a daily wage labor. I didn't want him to re-rupture his weak shoulder. So I did tell him, give it a 6 months time from his company to go back to the routine work.
Right. So excessive strain and stress due to work relation was one of the major reasons. Perfect. Exactly. Right. So how about pediatrics? Have you had any cases of pediatrics where you've seen something like that?
Very rarely, Dr. Swatika, but just pediatrics, yes, it can happen, and you have to be very careful in choosing pediatric when if they in case have a dislocation beyond the age of so we have to be very careful when you're trying to mobilize or reduce it off, because their proximal physis is in place, the humeral physis, and we have to make sure we do it gently. And after that, even if they have a laboratory, I don't try to do any repairs, and then we just wait for the bone to mature. And then only we think about doing anything beyond the age of 18 or 20, we test, because the labrum, they do heal with time because they're a little more vascular in nature compared to a matured labrum.
Fair enough. Thank you. We have somebody who said that thank you for a great presentation in your practice, and has asked if you would like to use PRP injections as an alternative to arthroscopic surgery for labral tears.
Honestly, PRP is something which is very new, and probably I might use it for bicerebral tendonitis, but not more than that. I mean, I don't think it's going to have much of a response on a labrum tear. I don't know if anyone has had any experience with it, and not much of literature has been published for the same.
Okay. Do you have currently, or there's another question, which is, do you have any patients who were sportsmen whom you managed and had to treat them within 6 weeks? Would that be a reasonable amount of time for them to get back into playing, or it is always has to be 3 months?
No, that depends. I think it depends on the lesion itself. If there is a lesion, yes, we do have to give enough ample time. If there's a significant tear, we have to think about some of them. It's not everyone every day will say that I want to get a surgery done just for going back to cricket or playing badminton. It's like, it's pretty difficult for certain people to accept they need to get a arthroscopy done. In this part of the world, yes, some of them, the youngsters do want to get it done, but then after that, they don't try to go to the pre-injury level, having the fear that they would have to undergo this procedure again. In fact, we do say that there's a chance of re-tear as well. But then I had experiences where, especially with cricket bowlers over here, coming back telling me that they want 6 weeks. Within 6 weeks, they want to go back to the game. Which I do put them through a physical therapy normally, but that wouldn't be enough sometimes. Again, it depends on the lesion which we look at, and if they don't recover with physical therapy and we do see something in the MRI, then we give them the choice. We do give them the choice. Then we put them through an extensive program, and sometimes try injection cortisone, which is another option, and then we'll see. We observe and see.
Great. And since you said cricket, do you see a large number of patients who come because of playing a particular sport?
See, this injuries in US is more common among the baseball pitchers, but here in UAE, it's more among the cricket bowlers. And I've seen that a lot of cricket bowlers. Even badminton, people who try to smash a lot, they get it. But
yeah, I was about to say, what about tennis and badminton? Yeah.
It's very, very common, very, very common. Because badminton, you go overhead and try to smash it. Tennis is okay, pretty okay, yeah.
We have another question, which what is the role of steroids in labral tear?
Labral tear doesn't have any role, but when it comes to slap lesions and your patient is more than 40 or 50 years of age and he's not going to be very active with the shoulder, he's not going to go on for playing so actively, and he's having significant pain, I'll definitely think about, doing an injection of a cortisone to reduce the inflammation which is going on there.
Great. So I think that's pretty clear as to the use of steroids in labral tear. So with that, Dr. Prem, we would like to thank you so much for patiently answering those questions and giving us insight into so much about how the shoulder can be fixed, and especially if you injure it during sports. Thank you so much. It was a great presentation, and from all of us, the organizers and our delegates, have a great evening. Thank you, everybody. Take care.
Thank you.